Well, good afternoon, everyone. My name is Dina Gaid. I'm a postdoc fellow at the School of Rehabilitation at Saskatchewan University. I'm a middle-aged college woman wearing blue shirt with orange scarf, with shoulder length, light brown hair, brown eyes with eyeglasses, with virtual background of bookshelves. So today I will present a systematic review with a meta-regression on enrollment, adherence, and retention rates among musculoskeletal disorder rehabilitation practitioners in knowledge translation studies. Next slide, please. Musculoskeletal disorders are one of the most common health conditions worldwide and are costly to healthcare systems. Musculoskeletal conditions are associated with a high economic burden globally, estimated at 37 billion in 2010. Rehabilitation practitioners such as physiotherapists, occupational therapists, chiropractors deliver care to over 11 million Canadians with musculoskeletal condition, with estimate increase to 15 million patients by 2030. Substantial research practice gap among rehabilitation clinicians persists despite the availability of clinical practice guidelines to inform the practice in rehabilitation. Knowledge translation aims to promote the use of research evidence in healthcare systems, targeting multiple levels of outcomes, whether professional, patients, or organizational outcomes. Next, please. Low enrollment, adherence, and retention rate are major factors that can contribute to the success or failure of KT intervention and also influence the estimation of effectiveness of any intervention. So assessing those rates may help researchers to develop more appealing KT intervention that practitioners can easily accept and sustain into their daily practice, and also can improve the design of future trial and consequently increase their validity and generalizability. Yet, enrollment, adherence, retention rates have not been described in KT studies. Next, please. So this systematic review aimed to estimate the enrollment, adherence, and retention rates of KT interventions targeting rehabilitation practitioners in charge of patients with musculoskeletal disorders, and also to identify the factors that likely affect those rates. Next, please. So a search strategy was developed in a collaboration with health science librarian to ensure that we capture the maximum number of study in rehabilitation science. The search strategy included subject heading, mesh terms, keywords, and synonyms for musculoskeletal disorders, knowledge translation, and rehabilitation. We searched published literature in scientific journals in 5 databases: Alvin Medline, Embase, PsycInfo, CINEAL, and Cochrane database in English language. We searched those databases from inception to October 2020. 3 independent reviewers screened the title and abstract of identified records by applying the eligibility criteria. And the same reviewers then independently assessed the full text of potential eligible study. Next, please. We followed PICO format to set the eligibility criteria. For participants, we include all types of rehabilitation practitioners, including physiotherapists, occupational therapists, osteopathists, and chiropractors, managing patients with musculoskeletal conditions. For interventions, we include KT interventions selected based in ERIC classification, which provide a comprehensive catalog of KT interventions that can be used in implementation research and practice. For outcomes, we target the 3 visibility measures: enrollment rates, defined as the proportion of participants who accept to participate in the study over all eligible participants invited to the study, and adherence rate, defined as the proportion of participants who completed the intervention over all participants who assigned to the intervention group. And also retention rate, defined as the proportion of participants who completed the intervention through the first follow-up point over the participant who started the study in each group, whether intervention or control group. For the study design, as recommended by EBOC systematic reviews, we included randomized control trials, across the randomized controlled trials, non-randomized controlled trials, and before and after study. Next, please. For data extraction, we extract data related to study characteristics like year of publication, country, study design, study duration, a number of study group, number of follow-up points, and number of outcomes. And also we extract data related to the KT intervention themselves, like the type of KT intervention, number and duration of KT intervention in each study, mode of delivery, and the intensity of the intervention. For practitioners, we extracted data related to practitioner age, profession, type of musculoskeletal disorder they manage, and also number of practitioners approach or eligible to the study, and practitioner who refused to participate and accept to participate, and practitioner assigned to each group, and practitioner who adhered to the KT intervention and who participate to the first follow-up points and the reason for refusal. Next, please. For the data analysis, descriptive analysis was conducted to describe each variable that possibly affect the visibility rate as proportions. And meta-regression weighted by the sample size was used to estimate the overall enrollment, adherence, and retention rate. Enrollment calculated for all participants, retention calculated for intervention groups and control groups separately, and adherence calculated for intervention group only. And the meta-regression model was used to assess the correlation between the potential variables and the visibility rates. Next, please. The search strategy yielded 6,088 records after removing the applications. Screening for title, abstract identified 105 potential eligible articles, of which 33 studies met our inclusion criteria. Next, please. For participating practitioners, most of the study target PT, physiotherapist, was around 70%, while the remaining studies targeting mixed type practitioners with 13%, chiropractors 12%, occupational therapy 3%, and osteopathy 3% only. While for the type of musculoskeletal disorder, the common type was back pain by 45%, followed by general musculoskeletal disorder 27%, and then neck pain 18%, osteoarthritis 6%, and rheumatoid arthritis by 3% only. The prominent type of KT intervention were educational meetings by 97%, followed by distribution of education material by 58%. Then audit and feedback by 30%, local opinion leader 24%, reminder 21%, facilitation 15%, educational outreach visits by 12%, ongoing consultation only 12%, and centralized technical assistant 12%, while the other or the rest of types of KT intervention was really less common than that. Next, please. So for calculating the rates, we find that the overall enrollment rate was 82%, ranging from 32% to 111 studies. Next, please. While for the adherence rate, we calculated the adherence rate for educational meetings intervention only. However, the calculated adherence rate can be well exemplify the adherence rate for the other associated KT intervention in each study, as educational meetings were mostly delivered concurrently with the other intervention, such as distribution of education materials, opinion leaders, facilitation, and audit and feedback. And we found that the overall adherence rate was 74%, 73% for before and after study, and 78% for control trials. Next, please. While for retention rate, we find retention rate was 65%, 49% for before and after study, and 81% for controlled trials. And for controlled trials, 80% for intervention groups and 81% for control groups. Next, please. And here, for the factor affecting each of those feasibility rates, we find that for enrollment rate, the study-related factor, enrollment rate can be increased by 12% if we have a study have more than one study group, and increased by 11% for the study who have more than one follow-up points, while it decreased by 12% for before and after study compared to control trials. While for the practitioner-related factor, we find that the enrollment rate increased by 33% for enrollment practitioner who managing back pain, while it increased by 19% when we enroll practitioner managing neck pain. And for KT intervention-related factor, we find that enrollment rate increased by 16% for KT intervention that delivered virtually or online intervention, and increased by 19% for educational meeting, which lasted more than 4 hours, and also increased by 29% for educational meeting when it's provided more than one time, while it decreased by 38% when we deliver between 2 and 3 intervention, and it decreased by 16% when we deliver more than 3 intervention together. Next, please. While for the adherence rate, we find that the study-related factor that adherence rate can increase by 27% when we measure more than 2 professional outcomes, while it decreased by 11% when we have more than 1 follow-up points. And also it decreased by 13% when we implement the study over 6 months. While for practitioner-related factor, we find that the adherence rate decreased when for practitioner who manage back pain, and increased by 13% for practitioner managing neck pain. While for KT intervention-related factors, the adherence rate increased by 16% for educational meetings that lasted more than 4 hours, and increased 12% for educational meetings that provided more than one time, and increased by 21% when we deliver KT intervention for longer period, like up to 6 months. And it decreased by 22% for 2 to 3 intervention delivered. And also it decreased by 32% for KT intervention when it delivered virtually. Next, please. And lastly, for retention rate, for the study-related factor,
it's 3 o'clock.
Rate can be increased by 31% for studies that have more than one study group, and also increased by 14% when we measure more than 2 professional outcomes. And it decreased by 31% for before and after study compared with control trials. And it decreased 22% when we implement the study for more than 6 months. And it decreased by 29% for studies that have more than 1 follow-up points. While for practitioner-related factor, retention decreased by 12% for practitioner managing back pain. And for KT-related intervention factors, we find that retention rate increased 13% when the educational meeting provided more than one time, and it increased 29% higher when the KT intervention lasted longer, up to 6 months, and it decreased by 31% when we provide 2 to 3 intervention, or 13% decrease for more than 3 intervention delivered. And it decreased by 35% when we provide the KT intervention virtually. Next, please. So as a conclusion for all of these numbers, we can say that this review support designing study with more than one group of practitioners with a controlled arm, and design a study for a shorter period of time, less than 6 months. And also the study should have only 1 follow-up point, no more. And also supports design a study with single intervention for short period of time from 1 month to 6 months, and also conducting long educational meetings for more than 4 hours, and deliver those educational meetings more than one time. Kind of repetitive educational meeting is more appealing. And these findings can be explained that practitioners have difficulty to commit to KT intervention within their busy daily schedule over a longer period of time. And also practitioners have limited ability to report outcome over multiple follow-up points. So concentrate on one full day workshop offered multiple times is better than having several short meetings during their busy working day. Next, please. This review has several limitations. First, several studies failed to report on the number of practitioners who were eligible to participate in the study. Also, second, other variables that could influence the visibility rate, such as practitioner educational backgrounds or practitioners' belief in KT interventions, we cannot consider those variables due to lack of information. Third, assessing the impact of each type of KT intervention separately on the feasibility rate was not possible due to the overlapping of KT intervention in each study. Also, the included study failed to report the number of participants received each KT intervention separately. Our findings are restricted to KT intervention targeting musculoskeletal condition rehabilitation practitioner only that may restrict like applying those findings on other healthcare disciplines. Next, please. As a take-home message, we can say that single intense KT intervention, high frequency, short duration was more appealing for practitioners. Interventions which require less effort and less commitment and which save practitioners' time have a higher visibility rates. And also, KT researchers should consider the time required from healthcare practitioners to participate in the KT study to maximize the visibility rates. And then this can increase generalizability of their findings. Thank you, and happy to receive your question if you have.